Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of FFS-For Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hello and welcome back to the As a Woman podcast. I'm your host, Dr. Natalie Crawford. I'm board certified in OBGYN and REI, and today we are talking about updates in fertility research. I think it's so important to stay up to date in research in all fields of medicine, but especially when it comes to reproductive health. And the reason why is that things are constantly changing and evolving. If we even think about what a fertility doctor did 40 years ago to today, it's vastly different. The oldest IVF baby is over 40 years old, but not 60 years old. So this is still a really new field. And even from the time period when I entered it 10 years ago until now, things are being done so differently. And I think that's amazing and wonderful. And in addition to being nerdy and loving hormones, I love research. I love science. I love data. You guys know I'm always saying you can't make decisions on data you don't know. That's part of the reason why I got my Master's of Science in Clinical Research and Fellowship. And you may not have known this about me. When I was an OBGYN resident, I actually started in the emergency room for a year. I did my intern year in the ER, realized really quickly that I needed a greater relationship with my patients, and transitioned over to OBGYN. And as a part of that, I really had a deeper understanding about what I wanted out of medicine and what I needed to be fulfilled in a job. And I wanted to be challenged. I wanted to be the person who knew what to do. And I wanted to be the end game, for lack of a better word, for somebody's problem. So really quickly, this led me to want to do REI, which is really hard to get into. And so I made a plan, and my plan wasn't just to hope and see what happened, but it included doing things that would prepare me to match into fellowship, because it is a match and most places have only 1 to 2 spots, and there's typically around 40 spots open each year. So in my residency, I worked for a couple years in a basic science lab, pipetting pituitary cells. I grew out pituitary cells and tested different reactions and enzymes. It's much longer and more boring than I'm going to go to in this podcast. However, it was so eye-opening to me, and honestly, it changed my life. And the reason why is because, one, it was hard, but I showed up. After 14-hour shifts, 12-hour shifts, terrible shifts, I had to go check on those cells and keep them alive. And I put in the work, and that allowed me to go and have papers published and have a poster to present. And when I went on my interviews for fellowship, I realized really quickly that my research mentor in the lab, who I otherwise would have never been connected with because she so rarely practiced clinically, she was my biggest supporter. The hours, the time you put in, the heart that you give something, I knew very well, and she knew very well, that I was not going to be a basic scientist in REI. That was not going to be what I wanted from this job. And she knew it. But she saw my dedication and how I came in, how I asked her questions, how I studied, and I worked hard. And she wrote me a beautiful letter of recommendation. And if you've applied for anything, letters of recommendation are so hard because you don't really know what they say. You just have to hope that you're gauging the situation right, and that if somebody is not going to feel comfortable writing a good letter, they would tell you. But I was really fortunate because I went on these interviews, and the field is so small. Any job, anything you're going to do, I want you to know the field is so small. People in every line of work, there are connections more than you know. And I don't think I really grasped this, even though everybody says it in medicine. But I went on these interviews, and every single person I sat down with, they knew Lisa Halverson, and they knew the letter she wrote me because she didn't write letters like that. And that's the reason my pituitary cells in a basic science lab in Dallas, Texas, that I cried over, and I spent hours in that lab. That's why I get to do the job I do today. So hard work often starts in maybe a place that you know is not going to be your ending, but it has a very definitive purpose in your life. When I was in fellowship, most people do a basic science project. So in REI fellowship, it's 3 years long. So at this point, I'd already done a year of emergency medicine, 4 years of OBGYN, and now I'm at my 3-year REI fellowship in North Carolina. And you have to do, this is so interesting too. When you sit for your boards, there's always a written and an oral boards for OBGYN, and then again for your subspecialty. So for REI, I had to go through the same process. And for your oral boards for REI, an entire section is defending your thesis. So you have to have a scientific published project, and you sit there for hours and get drilled on it, the statistical methods you chose and the methodology and what you would have done different. And most people do basic science projects because they're just more finite, more concrete. But I had already given a couple years of my life to those pituitary cells, and I knew there wasn't much more to learn from that experience. Meaning a basic science project in my fellowship would have been fine, and I would have passed the thesis portion of my test, of course. But no. This is fellowship. This is my time to learn. And half of that 3-year fellowship is totally research, and half was clinical. So I did clinical research projects all about natural fertility because you know me. And I got my master's of science in clinical research. So I went back to class, went to grad school at UNC, which they have an amazing school of public health. And I really, really learned about developing and evaluating and analyzing clinical studies. So I love keeping up with clinical studies. And it's one thing that I've always tried to bring here and share with you what is new and what is happening and what is changing inside reproductive medicine. But today I want to try a different format because often I know sitting here having me ramble on for 30 minutes about one single scientific study, I'm still going to do it sometimes. But I also think that there's merit in just giving you some quicker, bite-sized updates on what's being published lately, and then evaluating that or explaining it a little bit more. So that's what these nuggets are today. These are clinical updates from Fertility and Sterility, which is the leading REI journal. So if you want to know what your fertility doctors are reading in our journal, here we go. This is going to be the updates for you. All right, we're going to start by talking about anti-Müllerian hormone, so AMH, and specifically AMH when it comes to PCOS or when it comes to vitamin D. So there's a study published in Fertility and Sterility, and it was called Anti-Müllerian Hormone Level Predicts Ovulation in Women with Polycystic Ovary Syndrome Treated with Clomiphene and Metformin. So what we're looking at here is trying to see if a blood test, your AMH level, can help me predict if you will respond to this treatment option. And this is really important because one thing that everybody with PCOS will tell you is that some of the frustration comes from the uncertainty and the canceled cycles and the no response and feeling like you're just on a hamster wheel. Remember that AMH is anti-Müllerian hormone, and it is a hormone that's made from the cells that surround all of the eggs that you have. It is going to be released into your bloodstream, and it's really released by the follicles that have been sent out of the vault that month. So I like to use the analogy that all the eggs you're ever going to have are inside your vault. Each month, a group of those eggs is sent out of the vault. Number of eggs that are sent out is proportional to the number you have remaining. Each of the eggs are surrounded by what we call granulosa cells. So the egg is microscopic, lives inside a follicle, which is a fluid-filled structure, and that follicle is surrounded by granulosa cells, which do make AMH. In essence, the more eggs you have remaining, the more that come out every month, the higher the AMH value you have. Now, PCOS, polycystic ovarian syndrome, has long been associated with having a very high AMH or a very high antral follicle count because the disease if you've heard me talk about it, you've heard me say a lot of the origin of PCOS is having too many eggs in your vault. So your body is adjusting by sending more out every month. Your brain doesn't know this and it sends out its normal amount of FSH. Remember that FSH is the hormone, follicle stimulating hormone from the brain that is sent out to get one of those follicles or one of those eggs to grow. So what happens is that the brain is then sending out FSH. FSH gets a follicle to grow. And as that follicle grows, the egg matures, makes estrogen, and tells the brain, hey, we're good. We don't need any more FSH. And that's the normal check and balance control system so that humans only have one baby at a time and we don't have full litters. Well, in PCOS, if you have too many follicles, the brain doesn't know, sends out its normal amount of FSH, and this FSH gets diluted amongst all the follicles, and you do not get that reliable, predictable response to ovulation. Sometimes it takes longer. You have to see more FSH to get that response. And you might classically have those very delayed long cycles, 40 to 60 days, or absent cycles altogether. What we know is that the more eggs you have, you're going to have a higher AMH value. And every fertility doctor is going to tell you the higher your AMH. I can look at some of them and just subjectively say, it's not going to be a very good probability you're going to respond to this cycle because we've seen that the higher AMH, meaning the more follicles you have, it is going to be hard to induce ovulation with oral ovulation agents. So if you have PCOS and you have irregular cycles, if your tubes are open, the uterus is normal, and the sperm is normal, first line of defense is going to be, let's see if we can make you ovulate again. And so ovulation induction is with medications like Clomid or Femara. These medications are cousins. They work similarly, but a little bit different. So what happens is Clomid is going to bind the receptors in the brain and tell your brain that there's no estrogen remaining. Your estrogen then is lower, so the brain will be surprised, it will sense, it will interpret that low estrogen, and suddenly, whoosh, it's going to send out a stronger signal of FSH. And hopefully that's a strong enough signal to get an egg to grow. But we don't know. And the thought is that if there's still a ton of eggs, that might be still not strong enough of a signal to get the egg to grow. Letrozole is another medication used. It's not evaluated in this study. It's actually the drug of choice for PCOS. Letrozole eats up estrogen in the periphery. What's important is that in PCOS, each of these follicles that are not responding, they're making the teeniest, tiniest little bit of estrogen, not zero. And that estrogen is actually preventing the brain from sensing the change or knowing that no egg is growing because it thinks an egg is growing. So if you can drop that estrogen down, the brain will also send out a stronger signal of FSH. But in this study, they were looking at women with PCOS who were undergoing treatment with Clomid and metformin and seeing if a certain AMH level was correlated with the probability of responding. Metformin is often used in adjunct with Clomid or other ovulation agents, especially in women with PCOS who have insulin resistance. There was a very well-known study published in the New England Journal of Medicine decades ago, and it looked at patients with PCOS and either gave them metformin alone, Clomid alone, or Clomid and metformin, with the idea that even metformin improves some of your metabolic parameters, but it can lower some testosterone production from the ovary, and so potentially that could aid in ovulation. And in fact, it did. People on metformin alone did have a higher chance of ovulating than on nothing. People on Clomid alone had a higher chance of ovulating than on metformin alone or nothing. And people on Clomid and metformin actually had the highest raw number percentage of people who ovulated, but it was not statistically different than the Clomid group alone. So the take home from that study was that metformin is not essential, adding it on to Clomid in order to try to help people get pregnant. And of course, since then, we now have studies comparing Clomid versus letrozole, and we know that letrozole is first line. But in this study, we had PCOS patients, and so this had 333 women who had PCOS, and they were divided into three groups. Listen to these three groups. Clomid, Clomid plus metformin, or just metformin. Those sound familiar, right? And we were trying to see that looking at the baseline AMH level to see ovulation rates, pregnancy rates, and live birth rates. So the mean AMH level in this group was 11.7. Just for reference, overall in women who are under 30, average AMH values are going to be about 2 to 4. So this 11.7 is very high. In fact, diagnosing PCOS, some people use an AMH, others don't, but the cutoff, if you're going to use it, it's going to be around 4.5 to 5. So you can see that the mean AMH being at 11.7 means that many of these women had very high AMH levels and a very high antral follicle count. So with each unit, each one, so if your AMH is 12, not 11, 13, not 12, with each unit of 1 nanogram per milliliter increase in baseline AMH, the odds that you ovulated decreased by 10% with treatment. And women with a high baseline AMH greater than 8 were significantly less likely to ovulate compared to those with a normal AMH of less than 4. And this association, meaning having a lower probability of ovulating when your AMH was higher, it persisted even when you controlled for age, BMI, how long you've been trying to conceive, if you had insulin resistance or not. Importantly, even in people at very high AMH concentrations, there was still ovulation that did occur. So there was no maximum level where they said nobody ovulated after this level. I also think it's important to say that the 3 different arms of this treatment, so Clomid alone, metformin alone, or Clomid plus metformin, they all were really similar in results, meaning the lower your AMH, the greater odds that you ovulated with the treatment. So when you start looking at this and you see that the higher your AMH, the more follicles you have, the harder it's going to be for you to respond to treatment, I think that's important information when you're trying to gauge what steps you should do. If you have a high AMH, it's greater than 8, we have to understand that ovulation induction may not work. It might. And I always frame this to my patients as this is a trial, a test. We're going to see if we respond. That's going to be step 1. And then your chance of success is not even going to be higher than your age-related chance. So if you're 35, you're going to have a 10 to 15% chance of getting pregnant if you ovulate. So we got to get to that first step of ovulation. That may be a very poor treatment plan for you if you're starting your first family, you're 35, and you want 4 kids. The math doesn't seem to play well, and this might support, in my opinion, accelerating treatment for people who have very high AMHs so that we don't waste time in anovulatory cycles, or at least putting them in the position of power, understanding, hey, the odds are this is not going to work since your AMH is over 8, but we're going to give it a try just to see, and frame it so that they know what they're up against. All right, moving on is to talking about AMH and vitamin D. So this study is titled Association Between Serum 25-Hydroxy-D and Anti-Mullerian Hormone Levels in a Cohort of African American Women. So these women were enrolled in the study between 2010 to 2012. And this is part of what's called the SELF study. So this is a study that is a prospective cohort where they are observing environment and lifestyle factors and fibroids. So it's the study of environment, lifestyle, and fibroids cohort. There was no real intervention here. This is just drawing vitamin D level and seeing if there was an association with AMH in these women. So important to note is that there has been prior studies looking at vitamin D and AMH, and that might seem interesting. Vitamin D is really well known when it comes to bone health. I think everybody knows that vitamin D, along with calcium, is really important to prevent osteoporosis and have strong bones. But vitamin D is also really important in reproduction. And you've probably noticed that fertility doctors and OBGYNs are checking vitamin D and replacing it. That's because vitamin D receptors are found in the eggs, the granulosa cells, the cells that make AMH, the endometrium, the lining of the uterus where the pregnancy implants, and get this, the placenta. So vitamin D is important in making hormones, growing eggs, and the implantation stage for an embryo. Vitamin D has also been identified as potentially having a role in the regulation of AMH expression, meaning something about how those granulosa cells work or they make AMH. But studies that have existed in the past looking at vitamin D and AMH have been conflicting, and most of them show that there's no association. However, a lot of this was in healthy patient populations where many people had normal vitamin D levels, so it might have been harder to determine association if vitamin D deficiency was more uncommon in those populations. Of these participants, vitamin D levels were really low in the cohort, meaning 70% had a vitamin D deficiency defined as below 20 nanograms per milliliter. We consider normal to be 30 or higher, and so 70% being lower than 20 is quite profound. Higher levels of vitamin D were associated with higher AMH levels. This study did look at different categories, meaning a linear trend with vitamin D and AMH, which is what we think of. Each point higher of vitamin D, what does that do to your AMH? It's associated with an increase. And also looked at categories, meaning if your vitamin D was less than 12, if it was between 12 to 20, if it was between 20 to 30, if it was higher than that. And what did we see in those different groups? The take home was that AMH was higher in the groups where vitamin D was improved. So lowest in the group with the lowest levels of vitamin D. Importantly, in this study, they did see that a 10 nanogram per milliliter increase in vitamin D levels did improve AMH production. So to me, that's very attainable, and it should support checking and treating vitamin D deficiency if we are seeing it. All right, next up is a menstrual cycle paper. Now, I like this one. So the menstrual cycle is influenced by weekly and lunar rhythms. Y'all, we are getting all woo-woo talking about the moon and your period. I love it. So the question here was, does the menstrual cycle have a circumception, like a 7-day rhythm? Is it associated with the moon cycle? The population was 35,000 European and North American women who were age 18 to 40. And this is a cohort study. So again, this is where menstrual cycles were just reported and evaluated over 3 full years. So there were over 300,000 cycles of data in this cohort. And what they were looking at is, was there an association between when your period started, so the onset of menstruation, and the day of the week, and between the onset of menstruation and the lunar phase, so where the moon was. So there was a 7-day rhythmicity of menstruation with a peak of beginning your period on a Thursday or a Friday. Interesting. This was observed in every age group. So no matter what age group you are more likely to start your period on a Thursday or Friday. Fascinating. So this circumception rhythm, this starting your period on a Thursday or Friday, was observed in every age group, every phase of the lunar cycle, and in every season. This was most pronounced when people had cycles between 27 to 29 days. And there was a small but statistically significant interaction between this rhythm and the lunar cycle. All right, well, this is really interesting. There had been older publications looking at what day of the week you might start your menstrual cycle on, looking at if there is a biological rhythm that potentially exists, and looking at different moon cycles. So previous studies looking at lunar phases have not evaluated with this circumception rhythm. So the question at hand here is truly, is there an interaction between external and internal factors on having your period? In many animal species, this is quoted right from the article, fertility varies with the seasons, but this relationship remains to be clarified in women. Seasonal changes in the daylight hours could have an impact on the menstrual cycle, and the possible association between the lunar phase and the menstrual cycle may depend on the length of the cycle, because a cycle of duration longer than 27 days is more closely associated with the circa-lunar rhythm. It's also established that your periods change as you age. So this is really important to look across such a large database. What is most impressive in these analyses, and I'm going to put these graphs on Instagram so you can go check them out at nataliecrawfordmd, is that when you look across the season, your age, the lunar phase, and the cycle length, you see a very similar graphic pattern for the start of the cycle to be on a Thursday or Friday. It's so impressive. All right, when it comes to the moon or the lunar cycle, I have to admit this is not my area of expertise. So if it is yours and I get it wrong, come and correct me so that we can get this better. But menstruation occurs less frequently in the waxing crescent in the first quarter than in the waxing, waning gibbous or last quarter. And this trend was confirmed regardless of cycle length or age categories. Interesting. Also, there's huge variation in the different seasons when it comes to these lunar cycles, which is the graph looks very, very different. So why do people even look at when your period begins when it comes to a particular rhythmic pattern on the day of the week or the season or the lunar cycle? The biological view is that there's some internal mechanism for these rhythms. This circumseptum rhythm, the 7 days, has been observed in other animals. So that could be something that biologically is part of menstrual cycles. If you look at external factors, then this could be changes that happen in the week or the weekend. You guys know that I think this is very interesting. That could be affecting your physiology. So that could happen in real life. It could also happen for lab animals that are being studied for their period cycle. And if we think about one of the most common weekly rhythms is the sleep-wake cycle. You have school, you have work, and that might be different during the week than on the weekend. This has been looked at in other types of medicine, so not necessarily looking at your period start date, but looking at how the weekday versus the weekend can be associated with chronic sleep deprivation during the week. You have instability in your circadian rhythm. You have more stress, higher cortisol. Sleep is also really important in your hormones. You've heard me say that so many times. So this sleep change might be reflected in your body's interpretation of that drop in progesterone and what ultimately gets you to have your period start. So to me, that makes more sense that your body is doing something different during the week that then by Thursday, Friday has resulted in how your body interprets hormone signals if it's close to borderline to be when you actually start bleeding. I think that's fascinating. And there's probably some combo of internal, external factors. When it comes to the moon cycles, just very interesting. There's a predominance of having your period around the full moon. So that's confirming the association between some combination with your moon lunar cycle. And those phases of the moon that had less often period start dates were the ones that didn't fall on that 7-day rhythm. All right, this is my favorite part. And so this part is what I'm going to read to you verbatim from the study. What are the advantages of knowing that menstrual cycles are affected by the weekly rhythm and are not independent of the lunar rhythm? This question is related to that of the impact of your professional activity, sleep, light, and potentially even pollution on human biology. This not only opens up a new avenue for preventing dysovulation, but also therapy such as chronotherapy and or light therapy. So the conclusion of the study is that although it's low amplitude, there is a circumseptum rhythm of menstrual onset in this very, very large data set, over 300,000 cycles. It seems to be influenced somewhat by the season, and it does not appear to be influenced by your age. There is an interaction between this rhythm and the lunar rhythm, which does require further studies. So this is, to me, further support that looking at your sleep patterns, your stress levels, and your day-to-day life, and try to be consistent, try to take care of yourself. All right, friends. Well, that's 3 updates on research that I found very, very interesting. Hopefully you found it interesting as well. I'm going to answer a few of your fertility questions that you leave on Instagram. Every Monday at nataliecrawfordmd, you can leave your own questions. Some will be answered on Instagram. Some will be answered on the newsletter at nataliecrawfordmd.com/newsletter. And some will be answered here in this podcast segment called For Fertility's Sake, FFS. You can also call the voicemail at 657-229-3672. Again, that's 657-229-3672 and leave a voicemail for one of our voicemail episodes. All right, here are your questions. I'm trying to conceive while postpartum and my period has not returned. Do you have any tips? Number 1, if you're breastfeeding, that's going to be the most common thing that's preventing your period from coming back. So I recommend that you stop breastfeeding or cut down immensely in order to try to drop your own prolactin and restore ovulation. If you're not breastfeeding anymore, then it potentially could be that you're either anovulatory at this moment, or if you had a traumatic birth, potentially you could have some scar tissue or something abnormal inside your uterus. If you're 6 months postpartum and you don't have a period and you're not breastfeeding, then I would recommend you go see your OBGYN or a fertility doctor for an evaluation. If you are breastfeeding, then I would stop. And if you've not had a period return within 3 months, then you should seek an evaluation. There are some medications we can give you to try to drop that prolactin more quickly and restore a normal ovulatory pattern and remove the suppression from the ovaries faster. Medications like cabergoline. But of course, you wouldn't want to do that if you are actively breastfeeding and you want to keep breastfeeding. Question 2. When does the placenta take over, and when do you typically transition off of progesterone and estrogen from an embryo transfer? So the placenta starts to grow in, remember, right away when that embryo is starting to implant. But it's not fully functional till about 9 weeks. Now remember, these weeks are all funny. The moment we put an embryo inside of you, you're 2 weeks, 5 days pregnant, even though the embryo is only 5 days old. That's because of old dating mechanisms, which went back before we knew when ovulation or conception occurred. So everything was dated back to that last menstrual period, which adds 2 weeks to what the gestational age of the actual baby is. So by 9 weeks of pregnancy, which again means that the baby has only been around for 7 weeks, but all the dating's the same to be consistent. So by 9 weeks, the placenta is grown in. Most places are going to wean you off medication or just cold turkey stop it somewhere between 9 to 10 weeks, and that's all very fine and okay. We do an every other day thing for a week and then have you stop. Prior lives, prior practices, I've just stopped and it's totally fine. I know it's scary to come off of progesterone and estrogen, but we have to trust the placenta to do its job at some time. And if not now, then when? It has a lot more important jobs to do than just make progesterone. All right, can high intensity exercise be a cause of a luteal phase defect? Over exercising or high intensity exercise with stress, those things can definitely be what I consider to cause hypothalamic dysfunction. And I think that this is one of the top causes of luteal phase defect or slight ovulatory dysfunction. I've described ovulation disorders in a spectrum before. So you have your perfect ovulatory cycles where that follicle grows, makes a corpus luteum, it lives for 2 weeks, you get your period. Stage 1 is going to be a shortened luteal phase. So you're still ovulating, but that follicle did not have a good enough foundation to be a good corpus luteum and make progesterone for the whole 14 days. So your period's shortened. You get that luteal phase defect, either a short luteal phase or significant spotting in the luteal phase. Then you have delayed ovulation, where your period starts spacing out, eventually skipping months, and then frank amenorrhea, which means no periods. We know things like hypothalamic amenorrhea. Extreme exercise, calorie restriction is going to shut your brain off totally, so your hypothalamus does not send out any more FSH, and then there's no FSH signal to get you to ovulate. That takes years to recover from. Hypothalamic dysfunction, to me, I like to think about the hypothalamus as the control center of the brain. It's like air traffic control. And if there's a lot of static coming in, it's going to be so hard for those controllers to hear the pilots. And that's how I describe stress, high intensity exercise, frequent exercise, especially with dieting. And it's not going to be a one size fits all, but all of these different things, lack of sleep, chronic illness, they impact how your body interprets your state of well-being. In your air traffic control system, if it has a lot of interference, because potentially you're doing HIIT exercise for hours and it's just overwhelmed by that stress burden, it might not send out enough of a GnRH signal to send out FSH appropriately to get you to ovulate, or LH to get you to support a corpus luteum. It's going to be different for everybody. So this is not a one size fits all. HIIT exercise is absolutely bad. In fact, in overweight women with PCOS, those who did HIIT exercise lost more weight, therefore had a faster return to ovulation. So this is one of those circumstances where we're really trying to get to the nitty gritty of the full picture, the full body. What is your period pattern? What's going on in your world? And what can you do to improve your chances of success? So can it be? Yes. Is it always? No. All right, friends. Well, I hope you enjoyed this episode. I will plan to do more of these if you like them. So please give feedback. Again, you can always ask your questions on Instagram at nataliecrawfordmd, or call and leave a voicemail at 657-229-3672. Thank you, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd, and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.